and I'm one of the hosts for the call today. I'm a quality leader with the BC Patient Safety and Quality Council. And the webinar that we're taking part in today is part of a series of webinars to support clinical care management. And clinical care management, or CCM, is the largest quality improvement initiative that's ever been undertaken in this province. So these are pretty exciting times. CCM is led by a steering committee, a central steering committee in BC that has representatives from the Ministry of Health as well as reps from every health authority in the province. And it's supported overall by our BC Patient Safety and Quality Council. And part of the work that we're doing in CCM focuses on improving care for critically ill patients. And glycemic control is the first provincial improvement initiative for this area of focus. So I think what I'm going to start with today for the webinar is just to introduce our presenters today. We're lucky enough to have two great presenters on the call with us, Dr. Juan Ronco and Dr. Peter Dodek. So I'm just going to give you a little bit about their backgrounds, and then we'll go on to the next slide afterwards. So Dr. Juan Ronco is a respirologist, an associate director, and an intensivist at Vancouver General. He's the former director of the Adult Critical Care Training Program at UBC. And in addition to his active practice in critical care, he's the clinical leader for the critical care improvement with the BC Patient Safety and Quality Council. And he was instrumental in helping us to develop our best practice guidelines for glycemic control and the measurements for quality improvement in our province. We also have with us today Dr. Peter Dodek. He's an intensivist at St. Paul's Hospital and a professor of medicine at UBC. He's the chair of the Critical Care Working Group within the Center for Health Evaluation and Outcome Sciences at St. Paul's Hospital. He teaches internal medicine, critical care medicine, and quality management in healthcare, and he teaches undergraduates, postgraduates, as well as practicing physicians. He's a published author many times over and has considerable expertise in the area of glycemic control and measurement. So before we get Dr. Dodek to begin talking, I'm just going to give a brief overview about the technology we're using. And before I do that, I'd like to get a sense of who's on the call with us today. So if you look along your top toolbar, right at the top of the slide, on the very left-hand side, you'll see a pointer or an arrow symbol. If you can click once on that pointer symbol and then click on the map to give us an idea of where you're calling in from today. So I'm going to pause for a moment while we do that, and then we'll get a sense of who's calling in and from which area of our province. You'll also notice, as I let those pointers build up, that all of your lines are muted to decrease the amount of feedback that we have on the call today. And so you won't be able to be heard if you speak. However, what you will see is that there's two ways for you to ask a question, and I'll go over those in just a moment. What I can see from everyone putting their pointers on there, that we have a lot of people from the Lower Mainland, which is expected. It looks like we've got some people from the island, which is fantastic. We have a group, it looks like probably a group dialing in from Trail, BC. So welcome, and it's nice to see you. We also have someone who's a little farther up north. So welcome to everybody on the call today. We don't have time to go over individual introductions, but I do want to give you each a warm welcome for joining us. And it looks like we've got someone also from the Kootenays. So welcome, Kootenay group, and maybe even from the Okanagan. Fantastic. Good turnout today, so we'll have some good discussions. So click a second time on that pointer and your arrow will disappear. So one of the other technological things I wanted to point out on the call is the way that you would be asking questions today. If you have questions of our presenters at any time, there's two ways to ask your question. The first one is to raise your virtual hand. So if you look below the list of participants, there's a little hand icon. If everyone could click once on that, and you'll see that your virtual hand has been raised. Fantastic. So you're all figuring that out. And if you click a second time on that hand, that will put your hand down. So leave your hand up if you have a question, and our presenters will be pausing and asking for questions from the audience at several times during their presentation, and we'll have sort of an open question period at the end. You will also see a green check mark for yes and a red X for no to indicate yes or no if a question is asked of the group. And the other way that you can ask questions is you will see a chat feature right below the list of participants, and you are welcome at any time to type a question into that chat and press enter or return on your keyboard, and that will send the question out to the group. So we'll be monitoring for questions that come up in chat. If anyone has a problem connecting to the audio portion of the conference, they can use the chat feature to ask a question. So I think it's 1:05. We're going to proceed now with our first presenter. And our first presenter will be Dr. Peter Dodek, and he's going to start with reviewing the rationale for glycemic control in critically ill patients. And then Dr. Ronco will follow with some of the measurement for quality improvement that we're planning for the province.
May I begin now?
Yeah, I'm just going to get you set up as presenter. There we go.
Great.
So you should be able to advance the slides to the next one now.
Yep,
and
done.
off you go.
Okay. Thanks very much, Shari, and welcome everybody to this call. I'm glad that you're all participating, and now it looks like we're up to 29. I feel like this is a kind of a voting session here. The numbers are just flying right in. So today, what I'd like to discuss is shown on this outline slide. First of all, just to briefly discuss hyperglycemia in the critically ill, why it's important and why we need to achieve glucose control in the first place. Then to describe some of the recent trials in glucose control in the ICU, which is the evidence that we're using to help support this initiative. Then to get a little bit deeper into the meaning of glucose control, what exactly is this about, what are the elements of it, and one of those elements is the measures, which I'll then focus on with an emphasis on one that we've chosen to help us in this initiative here in BC. Just before the end, I'll give a little quick word of advice about point-of-care testing. That's not the major thrust of this presentation, but I thought I'd just mention a couple little tidbits about that, and then some suggestions for action that will hopefully help guide this initiative. Well, let's begin with hyperglycemia and the traditional view of hyperglycemia, which I would say was the view that I was witness to during most of my training, in that it was considered to be normal in critically ill patients to be hyperglycemic. We just accepted it as part of a normal stress response, didn't do much about it, and felt that it was a short-term event that was probably harmless. However, we also knew that hypoglycemia was something that was dangerous in terms of particularly causing damage to the brain, and therefore the usual approach to managing hyperglycemia in the ICU until about a decade ago, or maybe a little longer than that, was that we would start insulin if the blood sugar was greater than about 12 and aim to keep it around 6 to 10. Again, around a decade ago or so, there were some centers that used insulin protocols, but not many. And this was more of an ad hoc activity rather than one that was explicit. Now, if we look at this slide here that is a figure showing how we get hyperglycemic, this is just to indicate that the sources of plasma glucose shown in the center of this slide include breakdown from the liver, from the fat tissues, from the muscle, and then, of course, the exogenous sources that we provide in the form of nutrition. And all of this leads to an elevated plasma glucose concentration. Now, why should we do anything about this? Well, the rationale is this. Hyperglycemia impairs neutrophil function, for example, and there are many other things that it does, but this is one that I'm focusing on, which of course is required to help combat infection. And incidentally, it's associated with an increased risk of death. So it's not just a process effect in terms of neutrophil function without any outcomes. There is a definite outcome effect, and that is their increased risk of death. And that's independent of whether the patient has underlying diabetes mellitus or not. Now, we also know that hypoglycemia is associated with an increased risk of death. And thirdly, we know that variability in glucose concentration, that is, wide swings in glucose concentration in critically ill patients, is also associated with an increased risk of death. So our rationale here is to keep patients from being hyperglycemic, hypoglycemic, and having too many swings in their blood glucose concentration. That's the goal here. So along came a paper about 10 years ago, almost exactly 10 years ago, in the New England Journal, this intensive insulin therapy in critically ill patients, which was a study in one center in Belgium. And this was had a startling finding. You know, around this time, there were very few trials in critical care that showed benefits. A couple had been published, but not too many where we had striking benefits in terms of decreased mortality. And this study showed there was a 34% relative reduction in the risk of in-hospital death in these patients. Most of them were surgical patients, and you can see if we look at the mortality in the conventional treatment arm here. I think if I can point to this right here, can everybody see my arrow pointing to that? That the mortality in conventional treatment arm was only about 10.9%, and then the intensive treatment arm, it was 7.2. Well, what was the difference between these two? Essentially, the nurses for the intensive treatment arm were asked to keep the blood sugar between 4 to 6 millimoles per liter. In the conventional treatment, they were not given that same direction, just do what you usually do. And so this was a very striking finding. Well, this changed practice, if you can believe it, and we all responded to this because it was such a apparently simple thing to do that would lead to an improvement in mortality or decreased mortality for our patients. Well, the same group then did a similar study in 2006, published in 2006, and this time it was in a medical ICU. But unfortunately, they did not find, when comparing the two groups, the conventional and the intensive treatment groups, any difference between the two. There was no significant difference in the death, short-term or long-term, between these two groups. So this was a little discouraging and left us wondering, well, what should we do, given that we have both medical and surgical patients, and often the boundary between medical versus surgical is not entirely clear. Well, a meta-analysis was published, and this was a couple of years later in 2008. And I don't expect you to read all the print on this slide, but you can see from this forest plot that, in fact, almost all of the confidence intervals include the null point, which is the line down the middle. The bottom line is this. In critically ill adult patients, tight glucose control, that is aiming for glucose concentrations between 4 and 6, was not associated with a significant reduction in hospital mortality, although that one study showed it, but was clearly associated with an increased risk of hypoglycemia. That was a strong signal that was observed in this meta-analysis. And another meta-analysis done by Don Grisdale here showed the same things. Some other details were present in that meta-analysis, but the same basic point. And then along came the NICE sugar study. Now, these are acronyms for studies that were initiated out of Australia and Canada, respectively. NICE was the Australian acronym, sugar was the Canadian one. And the two teams joined forces and conducted this study of intensive versus conventional glucose control in critically ill patients. The idea here was to be able to have a large enough study to detect a meaningful difference in mortality, long-term mortality particularly, but also to examine mechanisms of the effects. So this was completed and published in March of 2009, and what I'd like to do is just review the hypothesis and the main findings from the study. So based on previous work, the investigators, which included, by the way, people from St. Paul's, Vancouver General Hospital here in BC, and were participants in several hospitals in BC. The hypothesis was that there is no difference in the relative risk of death at 90 days between ICU patients who were assigned a glucose range of 4.5 to 6 and those assigned a glucose range of 10 or less. And so this was the aim of the two protocols, achieve 4.5 to 6 or something less than 10, but not in the hypoglycemic range. What did we find? Well, first of all, we were able to achieve what we had said we were going to do, that is to achieve a time-weighted blood glucose over the duration of the study, which went out to about, in some cases, up to 14 days. This is just showing the first 14 days for patients, that the conventional group's glucose was in the range of about 8, and the intensive treatment group's glucose was about 6.5. And so there was a clear separation between the two groups. If we're going to see a difference, we actually were able to distinguish the two groups. The findings are these. The main finding is shown on this slide in terms of mortality. There was no statistically significant difference at 28 days, but at 90 days there was. There was a higher mortality in the intensive glucose control group compared to the conventional group. And when we adjusted that mortality, that is, adjusted for various conditions that might be different between the two groups, whether they were surgical, the region of where the patient lived, that is, where the center was, that is, age, where they came from before they were in ICU, the severity of illness, and whether they were ventilated or not, there was still a significant increased mortality in the group that was assigned to intensive glucose control. This was startling, and this finding, I believe, changed practice back to what it had been before the change that occurred secondary to the Belgian study. Well, what else did we find? Here's the survival curve just to show you over time what happened here. In fact, it wasn't just a short-term difference in mortality. It was a long-term one where the two curves in the survival curve split even later after the ICU stay. So whatever was going on early in the ICU stay seemed to manifest itself out later and persisted out to 90 days. So what we're seeing here is a probability of survival over time, and you can see that in the conventional glucose control group, higher probability of survival than in the intensive one. In other words, more deaths in the intensive glucose control group. Now, what about some of the other complications like hypoglycemia? So here's blood sugars that were less than 2.2 millimoles per liter, and you can see that whether we look at the number of patients or the number of episodes, there were more events, more patients or more events in the intensive glucose control group. And by the way, this was not a big surprise because this had been observed in other studies. Even in the Belgian study, there was increased incidence of hypoglycemia in the intensive group, but their mortality was in the opposite direction. Well, this was an important red flag for us because hypoglycemia was not an incidental finding. It was also independently associated with all deaths, as well as deaths that were due to cardiovascular or infectious disease causes. So, in fact, it was probably a meaningful event given that it was also associated with death. Well, let me just pause now, just before we get into the actual the nitty-gritty of glucose control. Are there any questions about these studies and what they showed? Just looking for any hands that have gone up anywhere. I don't see any. I see a few people that are not paying attention, but other than that, no hands that have gone up. We can see right inside your computers, those of you who are looking at email. Anyway, no hands, so I will proceed. So what is the meaning of glucose control then? Well, what the nice sugar study showed was that we can achieve probably a safer condition if we allow the blood sugar to be 10 or less. Doesn't need to be 4.5 to 6. So probably somewhere between 6 and 10 is a safe zone. We don't know exactly which zone, if there is something that's narrower, because that was not tested in this study, but we know that the middle range is probably the safer place to be. So to achieve that goal, we need to, of course, measure the glucose concentration and do it accurately. We need to have a sensible and feasible approach to titrating insulin in patients who are hypoglycemic, and this usually means some form of an insulin protocol or algorithm so that we can guide our therapy according to explicit criteria. And then, in order to see how we've done over time, it would be useful to have some summary measure of all of this, that is of the glucose concentrations over time, so we can see how well we are controlling the blood sugar. So, to achieve that, we need to have measures, and let's just focus for a moment on the measures of glucose control. First of all, they can be divided into two broad categories: central tendency and variability. These are just fancy ways of saying what's the average, pretty much is the usual way of expressing that, or versus the spread or dispersion of the blood sugar. So within central tendency, we have average, we have a time average, which is simply an area under the entire curve of glucose over time, or there is a derivative of that called the hyperglycemic index, which is the area under the curve above a certain threshold. In other words, your upper limit, for example. What upper limit are you willing to accept? And the area under the curve above that would be the danger zone, so to speak. Another measure would be median. Under the category of variability, We can look at the mean amplitude of the glucose excursions, standard deviation, coefficient of variation, the range, the maximum. There are various other terms here, the glucose lability index, the rate of change of glucose over time, some of the hyperglycemic indices, or what's called a glycemic penalty index, which I'll show you in just a moment. These are all measures of the spread of the glucose, the variability of the glucose. So here's the hyperglycemic index, an example of it. For example, here we're looking at the area under the curve above a value of 6 millimoles per liter. And you can see the shaded area is that area, and we simply add up those areas. There are ways of calculating these areas using formulas. Once we plot glucose over time, it's not terribly complicated, but it's something a little bit more complicated than you can just do on the back of a napkin. We get this what's called hyperglycemic index. In this case, it's 0.73. And what we do is divide by the time that the patient's on insulin or being monitored, just so that we can normalize it. Obviously, if the patient had a longer hospital stay, they'd have a larger area if they had more of these little peaks above the threshold. In contrast, if they were only in the hospital or in the ICU for a few hours, then they would have a smaller one. So we normalize it for the time at risk. In this case, we can plot it on the same curve here. In this case, it's plotted at this line. So that's the hyperglycemic index, and it's a kind of a handy tool, which I'll come back to for measuring being a measure of blood glucose control. Just to illustrate these other measures that I've mentioned, the glycemic penalty index, a little bit more complicated, but essentially, here's the glucose range on the x-axis, and here's the penalty, if you will, how much of a penalty or how many points you get for being outside the normal range. So in this case, this is in the American units of milligrams per deciliter. If we accepted this down here at the bottom as the normal range, for every bit that you're out of that normal range, you would acquire more of a penalty. And so the sum of those points, whether you're too high or too low, would then be an expression of the penalty. It's a bit complicated, but it has been used and has been published, as you will see in this publication I refer to. Another one is the glucose variability, and this is just to illustrate to you in this study from Hermanides and colleagues that the standard deviation by itself is not sufficient. This patient and the next patient have the same standard deviation of their blood sugars, but you can tell that the variability is wildly different between the two. The second one having much more variability. So another measure such as the change of glucose over time for each hour would be a better way of tracking variability if we're going to look at that. Now, we've chosen to use the hyperglycemic index for this critical clinical care management initiative, and the reasons are these. First of all, it's a measure of central tendency that incorporates time. It's not simply an average blood sugar or something else that is not does not incorporate the whole effect of time. In one study that assessed this index, this measure had the highest area under the receiver operating characteristic curve for a 30-day mortality. In other words, that it had optimal sensitivity and specificity compared to several other measures that were assessed. And similarly, in a multivariate model, that is a regression looking at determinants of 30-day mortality, it was the only significant glucose index compared to other glucose indices, not areas, but other measures of glucose control. This was the only one that was significantly associated with 30-day mortality. And so it has some credibility in terms of these 3 points. What I'd like to do is just show you some examples from real data that come from St. Paul's Hospital of actual glucose over time and how we calculate this. So I asked one of our clinical biochemists to send me some anonymous glucose over time data. Now this is just from glucose measurements from the lab, does not include point of care measurements. And I will show you 2 patients that are anonymous here. And this is example 1 where we included all the observations. And I'll tell you in just a moment why I mention this, all observations. Here is the area under the curve down below on the far left here that is above the threshold. And I chose a threshold of 10 just arbitrarily here. But it's the area under the curve above 10 divided by the total hours that were observed. In this case, that number is 1.41. So that we'll call method 1. And a second method, which is a similar index, this time it's assessing the time, total hours when the glucose was greater than 10 again, divided by the hours observed. So it's really the sum of these intervals when the glucose was above 10, here and here. And then we express that over the hours observed, and you can express it as a percentage, for example, 45.4. The third method is a method that had been promoted by some people who are looking at glucose control, and what they simply said, well, why don't we just count the number of observations when the number of points when the glucose was greater than 10, and then just divide that by the total number of observations. Sounds simple and perhaps useful, but let me illustrate to you why that's actually not a great method. So in this case, the measure here was 52.9%. So same patient, same measures, but what we decided to do is just remove a few. Just, for example, let's say we weren't measuring as many glucose measurements in this patient. So we removed a few in a random way, and here's what happens. The area under the curve, whether it's area under the curve or total time when the glucose is greater than 10, didn't change very much at all. But the total number of observations did. I'll just go back a slide if I can do that. You can see that we went from 52.9 down to 42.8. So that's a fairly significant drop in the percentage of points. And that's just removing points. So if there's some centers, for example, that don't measure as many glucose concentrations, this is the kind of bias that can occur. Let me show you another example. Here's another patient in which we're including all observations. This time, method 1, that is the area under the curve above a threshold, was 0.78. And the total hours was 37.6%, and the total number of observations, counting points over total points, was 32.3%. That is those that are above the threshold of 10. We go to the next slide. We cut out some random observations, and you can see that these numbers in method 1 and method 2, that is the area under the curve or the total hours, hardly changed at all. I'll just go back. You can see hardly changed at all, but the percentage of observations went down quite a bit compared to this baseline when all observations are included. Same patient, just a few less observations. So we're recommending that we use one of these two. Either one are probably acceptable, and to be honest with you, they can be calculated using the exact same measures. It's for no extra charge. So let me just pause here before I get into the point of care testing. Are there any questions about the hyperglycemic index as a choice of measure of glucose control in the first case here? I'm just going to scan through the list of participants and see if I can see any hands. And I don't. I see one of the pioneers in this area, that is Glenn Brown, is on the phone here, who was one of the pioneers in using this method some years ago when we did this at St. Paul's Hospital.
So Peter,
seeing no questions, let me just, sorry, there's somebody wanted to say something?
No, it's just Shari here. I was just going to say I don't see any questions from the audience, and there's nothing in the chat, so probably free to go on at this point.
Okay. So just a couple words about a point of care testing, and this is, again, as part of my literature search on this subject, I couldn't help but come across a few articles on this, and what was recommended based on the several studies I looked at was, one, in terms of accuracy of a point of care measure, use a sample of arterial blood, and for patients that have arterial catheters, that shouldn't be a difficulty. We can actually obtain it right from either a blood gas syringe or as a little drop right out of the blood, out of the tubing. And secondly, to ensure that the device that you're using corrects for the hemoglobin concentration because of the variability in blood glucose concentration depending on how many red cells are occupying the space, and that this is also accurate over a wide range of PO2. It turns out that oxygen tension can interfere with the assay, but for many of the better devices, it's accurate over a wide range, way outside the physiologic ranges. So that's just something to be sure of. So finally, just some suggestions, and this is hopefully will be a nice segue for Juan. Is one, to collect glucose concentration and time data for all patients who are on insulin infusions, and those are the patients that we're most worried about. You've found that these patients are hyperglycemic. You want to do something about it. So these are the ones that will probably need the control, and they're the ones that we're looking for in terms of a hyperglycemic index as the measure of control. So that's the second point. And just for those of you who have already thought beyond the hyperglycemic index, in the future, we could also calculate the hypoglycemic index. That is the area under the curve, below a threshold. In other words, below the safe lower limit. That's possible. In fact, from the same data, we could express that. For now, we will probably just capture hypoglycemic events, but it's also a possible measure. So we have that's the end of my presentation, and I know that Juan wants to go on, but I do see there's a question, and it says privately here, but I don't know whether I should read the question now or save it for offline. Maybe the person who asked the question in the chat room can let me know whether they want me to discuss it now or later, or offline later. If you can write something in there, I'll do whatever you want. Public. Okay. So the question was, what if we don't have an arterial line? Are we able to use venous? Well, if that's all you have, then that's what you will do. But you know, that it was just, if you had arterial blood, it would be the easiest, just because sometimes venous blood, particularly if there's an intravenous line there, can be diluted by whatever happens to be running into it. But if you can get a clear venous sample, then by all means. Any other questions? You're welcome. Okay, well then I'd be happy to turn over now to Juan for the next part of the talk.
Thanks, Peter, and thanks, Sherry. I think I want to make sure first that you could listen to me in an appropriate fashion, so I can keep up. I'm told that I should speak louder. I'm going to just see if I can bring up the volume of my microphone. Is it better now, Sherry?
It's a bit better. You might want to speak a little bit louder so everyone on the call can hear you.
Okay. I'll do my best, and feel free to interrupt me if I don't do justice to the sound in the system. So I wanted to think, first thing I wanted to do is to thank Peter for such a elaborate, well-rounded, and comprehensive summary of all the work that has been done, that only tributes him for all the work he has done on this. And indeed, I should say that it's an injustice to Peter that I have been introduced first and not him first, because actually he's done all the work. I'm only seconded him in all this, and obviously I seconded him with Sherry. I wanted to reiterate a few points that Peter brought up, and those are, first, the rationale for why we chose glucose control as a critical care management initiative. And the first one is the fact that hyperglycemia affects so many physiological functions and is also well known to be associated with changes in mortality. By the same token, hypoglycemia is also associated with a significant risk of death. And lastly, the fact that variation in glucose is also strongly associated thus far with an increase in risk of death. As such, and I would be fair to say that most of the intensive care units have adopted the use of insulin protocols. So I wanted to make a small note on that. For those of you who are using insulin protocols, that is fantastic. We appreciate that. And for those of you who are not using insulin protocols and algorithms to adjust glucose in the critical and to reduce variability and hopefully then decrease the side effects of glucose control or lack of thereof, that we will be happy, Sherry and I, to contribute and help with resources as much as we can to provide you with the tools that you need to establish in your own institutions and according to your own management criteria, glucose control in your intensive care unit. The last thing I wanted to reiterate is what Peter mentioned very eloquently, which is what are we trying to measure? Is we need to ascertain measures of central tendency with glucose control, and more so measurements of glucose variability while someone negotiates a critical illness in an intensive care unit. And to all what Peter says, then it will make perfect sense to you why we've chosen the average hyperglycemic index in these patients, and we hope to therefore capture the time, the central tendency, and the variability of the glucose control in those patients in an ICU. The second measurement that we are hoping to capture is the rate of hypoglycemic events per patient while they are in insulin protocols. And the purpose of this measurement is to ensure the hypoglycemic events do not rise in the attempts to perfect the glucose control of patients in the intensive care unit. I want to pause on this for a moment because this is something that most of the intensive care units that have implemented insulin protocols have been measuring and have paid attention already as a way of making their glucose control more effective. And furthermore, for those intensive care units that are currently reporting data to the critical care database that Peter spearheaded from St. Paul's Hospital and disseminated from there outwardly to the rest of the province, many of you are already contributing these measurements to the intensive care unit. So what we're asking you to do is to continue to collect these measurements, and we will help in the tabulation of that and help you with the use of the information if you needed such a help. And lastly, and in parallel with what I just said about contributing data and or doing quality assurance and control in your intensive care units, we would like to collect crude rates of mortality as well as standardized mortality by Apache score for each patient that is admitted in the ICU. We will extend that to hospital mortality and to 90 days and to a 1-year mortality as a way of strengthening the signal and the implications of glucose control in the intensive care unit. Before I move to the next part of the presentation, which is giving back the podium to Shari and to open it up for questions, I just wanted to emphasize that that only through the good communication, good cooperation, and good understanding of what we're doing, without any privileges whatsoever, we will hopefully move forward on this, and that our initiatives will not stop here with measurements of glycemic control in the intensive care unit, but with further consultations with all of you, they will continue to tackle other problems that are fairly prevalent in the intensive care unit, and where we perceive as a group and as a whole the need for continuous improvement. I'm going to stop in there, Shari, and give it back to you, and just to see if there are any questions for Peter, for myself, or for you for the rest of the presentation.
Great, thanks, Juan. There have been a couple of questions that have come up in the chat feature. One from Karen Mayo, who asks, what about capillary? And this probably goes back to the question Peter was asked about venous samples versus arterial samples. Peter, can you take that?
Sure. I mean, in the studies that I looked at, and again, these came up incidentally in my search on measures of glucose control, so it may not be an exhaustive search on point of care testing. Topic for perhaps another webinar maybe. But anyway, capillary and venous were generally inferior to arterial, but not completely flawed. So if that's all you have, then that's what you do. But that's the best answer I can give right now. I'd really need to look further into that, just to look at the reliability and the performance characteristics of capillary, especially with modern devices, because a lot of the concerns that we've had about these different sources were with older devices, and there are now some modern devices. I don't know if Juan, if you wanted to add anything to that.
No, just for those who are interested on this, and hence for the question, and the way that I would see this is in blood samples, we can measure glucose in plasma or glucose in whole blood. Glucose in whole blood has to take account the volume of distribution of red blood cells in plasma, and therefore the measurements of glucose in whole blood are usually higher than the measurements of glucose in plasma. So if you take into consideration that you have red blood cells, you have to correct for the concentration of red blood cells, and hence the flaw that Peter mentioned about correcting for hemoglobins when you are doing point-of-care measurements. Now, the new technology, as Peter mentioned, that has come to daily use now has ways of correcting in their algorithms for hemoglobin concentrations and hence hematocrits. The second problem with this is the issue of PO2. Well, significant degrees of variability on the PO2 may affect, at the point of care, the measurement of glucose. And so that's why also Peter put a slide mentioning that, and you need to be cognizant of that. Though the new technology, once again, has introduced algorithms to modify for this. But as Peter mentioned, pragmatically, if that's what we have, that's what we measure, and then we follow a trend, and each patient becomes his own control.
Thanks, Juan. I think that another question that has come up in the chat feature here is from a group in Kelowna who probably asked something that goes along with what you were just saying. It says, when this was presented at the Whistler conference a few years ago, it was suggested that the point-of-care accuracy was not very good when the sugars were low. Has this been reconsidered? Juan, maybe you can take that one as well.
Well, no, and so the use of, first off, as Peter mentioned in his slides, in the studies thus far, and particularly in the night sugar trial, glucose was measured via arterial sampling as a way of standardizing venous versus arterial, and not using point-of-care measurements. And so for those of you who have analyzers in the laboratory that are part of your arterial blood gas machines that have electrodes for glucose control, that is a satisfactory and rapid measurement. Now, the fact that that's what it was measured in the studies doesn't mean that technology has not modified itself to correct that. And we don't know the answer of that, and I don't know the answer of that if the now current point-of-care devices have minimized the discrepancy that usually is between 20 and 30% between measurements of glucose in plasma or whole blood using central analyzers and or point-of-care analyzers. Regardless, for practicality and for what I said before, each patient becomes his own control, and then the trend in the variability, right, will be minimized either way with the use of insulin protocols in intensive care. Peter, I'm not sure if you have something else to add.
Yeah, no, I think that's the main point. Just from what I've read in the articles that we're looking at, the accuracy of different, the different sites of blood drawing, and also for different devices, by the way, it looked as though the accuracy was pretty good over a range. Now, there is a little bit more spread. In other words, some variability at the very high ends and the very low ends, but not so much that it would be, I think, impossible to use these. And again, the more modern devices are even better than the ones from, say, even 5 or 10 years ago. For example, I know the one at St. Paul's was called a Contour, and I went to look up Contour and compare it, and studies that compared it to some of the others. And it's, I'm not promoting that particular device, but I'm just saying the performance characteristics were very good for that device. And so an issue of worrying about accuracy in that low range. We usually do, if somebody has low blood sugar on a point-of-care device, verify it with a laboratory measurement just to be sure, or if it's falling, for example, just to even verify with a laboratory measure. So I wouldn't stop using your point-of-care measures, but it's probably going to end up being a mix of the two that will be tabulated for this work that we're doing.
Great. Another question that came up in the chat was, are there currently centers that are capturing all documented blood glucose levels on all critically ill patients within their databases? And this is a great question, and this is something that we've thought a lot about. Because this is such an important issue for critically ill patients, and because this is such a fragile population, what we've done with clinical care management is look at some of these key reportable improvement measures and try and make it as easy as possible for sites to collect them. So there are some health authorities that are part of the central ICU database, and as part of that, we are working with Dr. Peter Dodek and the central administrator for that database to modify the data capture fields to add glucose and time. So the sites that are on those on that ICU database will have a chance to start collecting their data within that. But that's not to say that sites that are not currently part of that system can't just start collecting the data on their own. You can certainly do that. All you really need is an Excel spreadsheet to start recording your glucose and time, and certainly contact us after the call if you have questions about how to calculate that hyperglycemic index that Dr. Dodek was speaking about. And we can certainly help you with that. And we are working with key leaders within our provincial critical care working group to try and make this possible to collect all of these measures within every ICU in the province. So we are working hard on that.
Can I just add to that, Shari?
Yeah, go ahead.
So thanks for that. You know, what we're trying to do here is, for those of you who are ICUs or who are on the database, you will note that there is a screen to look for hypoglycemic events in patients who are on insulin. So the trade-off now is that we're going to eliminate that screen, so you don't have to go looking for hypoglycemic events. In exchange, we'll ask you to tabulate all the glucose and time measurements for the patients who are on insulin. And then we'll automatically find the hypoglycemic events. And then tomorrow, in fact, I'm having a meeting with the database people, the database programmer, just to see how we can incorporate this new screen, and in fact, how to incorporate the calculation of the hyperglycemic index so that nobody has to do any math on their own. We're not trying to give you more work to do. The only work that we're asking is entering the glucose and time values. And to be honest with you, it would be as easy to enter it into the database as it would be to put it onto an Excel spreadsheet. So we're hoping that even if that's one of the few things that you enter into this database, if you're starting to join the database, and we hope that most people will, that it would be the same work to put it into the database as it would into an Excel spreadsheet, and for free you'll get the calculation of your hyperglycemic index for all the patients. That's the goal.
Are there any other questions now from the participants on the call with us today? Anything that you want to ask verbally, we can certainly unmute your line if you put up your virtual hand. And again, that virtual hand symbol is right below the list of participants. You'll see a little icon that looks like a hand. Click once on that, and it'll indicate that you've got a question. We'll just pause for a minute. Okay, it looks like our presenters have done a great job of going over everything, so I don't think we have any more questions from the group, but certainly if you think of something in the next few minutes, then we will continue to scan for questions from the audience. So I'm going to move the slide now and go into some of the other support things that we're planning for as part of our support for clinical care management with the BC Patient Safety and Quality Council. So one of the things that we're doing, in addition to networking and building some partnerships and communication, is we're working on this series of webinars. This is our first one, the one that you've joined us for today. And our next one is planned for January the 16th. And we're calling that the BC ICU Database Project. So for those people on the call that have heard just for the first time about this ICU database and want to have a little more information about it, that's the webinar to attend. We'll talk about the history and the development of it, and then overall just talking about the use of data for quality improvement and what a key part of QI work that is. In February, we're planning another webinar called Choosing and Adapting an ICU Glycemic Control Protocol. And on this webinar, we're hoping to have teams from various ICUs across the province talking about how they chose and adapted their ICU glycemic control protocols over time. And this would be a key webinar to attend if you don't currently use an insulin infusion protocol in your unit. That would be a great one. Or if you do have an insulin protocol but are not completely happy with the level of glycemic control that you're achieving, that's the webinar to attend to sort of discuss how other centers are doing it, to be able to share protocols and practices, et cetera. And then in March, we're planning one called Feeding Practices and Patterns. And that one is just in recognition that that is a huge aspect of glycemic control in ICU. And there's a wealth of knowledge out there between the pharmacists and the dietitians and the nurses and the rest of the ICU multidisciplinary team that really impacts glucose control in other areas. I also wanted to direct you to a really important resource. And this is not part of our council, but it's a great resource for clinicians in BC. It's called Impact BC, and their website link is there below, www.impactbc.ca. And what you can find there are some excellent resources on quality improvement. So if you've been part of QI teams, you might have a really good understanding of how to do this. But if you've heard about these PDSA cycles and are not quite sure what they're all about, or you want to start something on your own, specifically about glycemic control, that's a great place to go to learn how to do it and what QI work is all about. The other thing I wanted to point out is our website. So I'm hoping that most of you have had a chance to check this out, and if not, please do after the call. So our website is www.clinicalcaremanagement.ca, and it's all about this clinical care management initiative that the Ministry of Health and the health authorities are leading, and some of the topics of focus. And you can see that in addition to care of critically ill patients, we are looking at improving hand hygiene, heart failure, med-rec, sepsis, stroke, TIA, surgical care, and venous thromboembolism, as well as many other topics that will be identified in future months and years in the province. So at our website here, you can find our contact information for Dr. Ronco and myself, and we'd be happy to pass on any queries to Dr. Dodek as well. You can also find a sign-up link for our BCPSQC newsletter, and that's an area that you can, if you sign up for the newsletter, you can certainly get advance notice of all of our support webinars that we're planning. You'll also find the guidelines, the provincial guidelines for glycemic control, the key reportable measures that we discussed on the call today, resources, references, as well as tools. And the more input we get from ICUs across the province, the more we can share those on our website. So if your ICU has a glycemic control protocol or an insulin infusion protocol, please go on there, find my contact info, and email it to me, and then I can share it on our website and others can learn from you. As well, on our website, you'll find a recording. In a few days' time, we'll have a recording of today's event for any of your colleagues who've missed it, and that'll be available on our website next week. So please check that out, and if you've enjoyed the call today, share that link with a friend and let them learn as well. Lastly, at the end of today's session, your computer should automatically direct you to an evaluation form. It would really help us if you take a few minutes to fill that out so that we can take that feedback and use it to improve for the next webinar that we've got planned. And then just in closing, if you have any further questions on clinical care management, you want to join in the discussion in a more meaningful way, or have something that you want to share and contribute, please get in touch with us. We'd love to hear from you. I wanted to just sum it up today by thanking both of our presenters for being here today, Dr. Dodek and Dr. Ronco. Really appreciate you taking the time out of your day to join us. And absolutely everybody who's dialed in today. We have great turnout, which means there's great appetite for improvement out there and great engagement within the critical care group. So I'd like to thank you all for joining us very much and hope to see you at the next webinar. Any closing thoughts, Juan or Peter?
Just in answer to the last question that appeared there in the chat, evidence to suggest that a protocol is better for glycemic control as long as sugars are kept between 6 to 10. Well, I would defer to my colleague Glenn Brown, who many years ago working with me, we tested exactly that question just in a before-after study. What's the difference between introducing a protocol versus having no protocol? And we found that our blood sugars were under better control, including the hyperglycemic index, and there were fewer hypoglycemic events. So, but that wasn't a randomized trial, and I'm not aware that there are any. But based on the whole notion of checklists and the value of protocols in other areas, and that little piece of evidence from St. Paul some years ago, I would suggest that a protocol is probably a better way of achieving tighter glucose control. And I say tighter, I mean within the range you want it to be in, than doing it randomly.
Thank you. So one last thing that we'll do, just in case there's call-in users who haven't been able to see the slides yet, you will be able to access them if you check out the recording, which should be up on our website next week. But for a moment here, we're going to unmute everybody's lines. There might be some audio feedback, but we'll just put up with that for a moment and just see if there's any call-in users who want to be able to speak but haven't had access to the web. Do that. All the lines are unmuted, and if you have a question, please up now.
Sounds like there's a fire alarm going off somewhere.
Sure. Well, I think we'll close up the call now. Thank you again, everybody, for attending today, and I hope you all have a good day and a good week. I hope you will join in on January for our second webinar in this. Thanks, everyone.
Bye-bye now.
Thank you for
Bye.
your participation. Bye. Sherry, are you still there?
I'm still here, Juan, and there's one other question that came up in the chat. Maybe we can answer that as others sign off. From Karen Mayo, and we'll just
How many medication errors are from interpreting the orders? Well, I don't think that I can answer that in terms of quantification, because we don't have records of medication errors in the ICU. I could answer the question indirectly from the internal validation data from the usage of insulin protocols in the intensive care unit.
Okay, maybe what we'll do is try and unmute Karen's line. I see that she's still on the call with us, so we'll try and unmute her and see if we can talk to her directly.
Hi,
Go ahead, Karen.
Hi, it's Karen Mayo. I'm here with my pharmacist Zara and another guest in my office, and we don't have a written protocol, and I've looked at several different protocols out there, which are very confusing and open to interpretation from nursing. And I just wondered if there was some SLS data out there as to how many errors have actually occurred. We're the ones that are nurse-driven, and our nurses range it from 6 to 10. And I don't think, looking at the data, because we're on the data spreadsheet, that our numbers are way out of whack. So I guess we're just looking for some backup to why we should change what we're doing.
Okay. First off, I'm not sure how are you doing this, but if you're not using insulin protocols, but sliding scales, I presume that that's what you're using to try to keep your glucose measurements within the range that you mentioned, correct?
What we're using is a physician will write an order to use insulin infusion to keep blood sugars between 6 and 10, and then the nurses are doing regular hourly or Q2 hourly glucometers and running the insulin infusions to keep the sugars between 6 and 10.
So indeed, then you are using an insulin protocol, because that's what we will call an insulin protocol. The only thing is that you're leaving the tabulation of the protocol to the insight of the nurse.
Correct.
Correct?
Yep.
Which in turn, I will suggest, I will like to believe, leads to more variability, because the nurses may be more prone to make mistakes in the judgment of how much insulin ought to be given for a certain swing in glucose control. The